part of that whole system. The TMJ communicates with estimated over 40% of the nervous system has some kind of connection with the temporomandibular joint, which is part of the cranial mechanism, of course. So you guys have all had some degree of embryology, I assume, right? Undergrad or maybe some here. Well, the bones and the muscles come from the mesoderm, the germ layers. The nervous system comes from the ectoderm. Of course, the organs come from the endoderm. A lot of the cranial makeup comes from the ectoderm. Excuse me. That garlic sauce. Ooh, I'd like to look too much of that. I'm sorry if I'm up close to you guys. It looks so good. It tastes so good. So it's just interesting to consider that, you know, how the body formed. It's not so much a mystery that we have this head that has all these points and reflex points, and that communicate with all the different layers of the body. You remember that, right? The nervous system comes from the outer layer, and the notochord forms, and then it infolds and does all those things. So anyway, the craniosacral-sternal mechanism can affect anything be affected by it. It is I threw these in here. You guys are familiar with the homunculus, right? Motor homunculus, and this is, I think, the sensory, homunculus. This one here, this is my favorite here. This guy just creeps me out. But that's how the brain sees the body. That's from a sensory motor compilation. The brain sees us that way, not the way we see ourselves. The proportions of representation neurologically of that versus so Dr. Sutherland, these are different people that are are credited with developing a lot of these concepts. Mark Pick is a modern day guy. I actually met him. I think he's retired now, but he taught down at LACC or whatever they call it these days. Years. He's a brilliant guy. He's written quite a bit of stuff on cranial work, and he also taught neuroanatomy there, and he did all kinds of interesting experiments with cadavers. Years ago at an ICAK conference in LA, he came and he had a patient, this is a bizarre story, but he had a patient, a little patient who had been living for years, and she agreed to donate her body to science, but specifically to him, and somehow he was able to make that. So this patient died. It's a true story. He dissected himself as a special project, and he did all these different experiments with the craniosacral methods, and you could see on the film the amount of movement that was going on in the craniosacral system with just a little bit of pressure. And while this thing was on the video screen, he came around to each one of us. There was probably 100 people, and he pressed on each one of our hands to show us how much pressure he was using to create. And it was amazing. So I already thought I understood craniosacral stuff at that point kind of well, but he really expanded my appreciation for it. So anyway, cerebrospinal fluid, of course, is the stuff that circulates, constantly being secreted and absorbed, which is a part of what creates the craniosacral movement. Fluid is being created, which creates pressure, and then it's being absorbed. So there's a sort of subtle wave going on largely from that. And then then that's enhanced by the movement of the brain. We produce, Dr. Goodheimer, I remember one time he said, we produce as much CSF in a day as we do urine. And half a liter. We produce more. Drink a lot, but water. But that's pretty weird to think about that we create that much. And so there's only about 150-ish milliliters in the system at any given time. It's constantly being resorbed. So anything that impedes that, with something that dynamic, that much fluid and physiology going on, anything that impedes that is going to potentially cause problems. Like sitting. Sitting for too long impedes our craniosacral. Sitting, driving. Anyway, every 24 hours, 4 times, we renew it 4 times. Pretty amazing to think that all that's going on. Most of it's produced in the choroid plexus. Let's see here. Oh, this is the makeup of it for those of you who are interested in this kind of thing. Most of it's water, obviously. It is a lot like serum, but it has a lot lower concentrations of these various things. What does it do? Well, it delivers waste products. It delivers nutrients to a certain degree. It maintains pH, but largely it creates protection for the central nervous system. So the brain weighs roughly 1,400 grams, but its effective weight is only 25 to 50 grams in the fluid. So literally, it's sort of defying gravity because of the because of the cerebrospinal. So that's what it does. It moves. The cranial bone motion is about 6 to 12 cycles per minute, depending on who you read. Compare that to the normal breathing cycle, which is about 12. It's about half. So as we get older, of course, our bones get less flexible. Our tissues, our myofascial matrix gets stiffer and less resilient, and so that wave motion becomes less wavy. When we start talking about the cranial bones, the sphenoid, we're going to talk a lot about the sphenoid, which is the keystone of the skull. And the sphenoid is made up of course, the main sphenoid and then the what they call it, the basilar portion, which communicates with the occiput. So the occiput and the sphenoid are literally part of the same mechanism. They're moving like this. This would be the front of the face. This would be the back of the head. This is happening all as we breathe. That's part of the cranial. You guys don't get any cranial work. It's just amazingly important. So there's all kinds of different different ideas about how to go about treating some. I mean, there's a lot of doctors don't recognize that this system is even significant. Maybe it was significant in utero, but it's not significant now. And you'll have a lot of doctors that will tell you that the cranial bones don't move. There's just a fused shell. And of course, that's not true. They move all the time. They're constantly moving and shifting. They have to, because they have to take up the pressure and kind of spring back. That's what creates the craniosacral rhythm. Blood pressure, and I can attest to this because I've used this many times. Blood pressure, one of the many things that can cause blood pressure to go up is poor craniosacral rhythm. So blocked. The nervous system will direct the cardiovascular system to push harder to try to get blood into the nooks and crannies if the craniosacral mechanism is hindered somehow. I do CDL physicals, have for years for commercial truck drivers, and you have to be federally certified to do these. I was talking to Elle this morning. You guys should all look into that when you get into practice. It is a freaking great way to generate income. You get lots of patients in that wouldn't otherwise. I'm sure that MDs can get certified. It's called Certified Driver's License, and it's over the federal government oversees the qualification of truck drivers for interstate. What's that?
You mean we're certifying them when they're healthy?
We are doing the physical, which allows them to get their CDL. And they have to get a CDL every 1 to 2 years, depending on their health. If they're on blood pressure meds or have blood sugar issues, they have to be certified every year. If they're perfectly fine, they can go 2 years. So I've been doing these for years, and it costs about $1,000 to take the training and the exams and all that. But I could see a dozen a week if I had room for it. I'd probably see 2 or 3 of them.
The trucking company paying you or the
Well,
person?
I have, so I have, the next county, in the county where I practice, I do a lot of the physicals for the county road workers, maintenance. And I also do all the physicals for the city of St. Helens. I do a bunch of them for the ODOT, it's the Oregon Department of Transportation. And then a lot of guys are just on a dump truck or do long haul. All different, but they all, school bus drivers have to have CDLs. So sometimes the company pays me, sometimes, Hudson Garbage, they're a big garbage company in our area, I do most of their drivers. I would do a lot more of them, except I can't get them in. Charge $125 cash for the exam. Takes me about 15. I have my office manager do the Snellen chart and the quick urine screen. You don't have to test for drugs, you just test for basic stuff, sugar, and you do basically a systems review, blood pressure and ortho-neuro, and review their meds. And it's a lot of them are pretty easy. Real healthy, they don't pay. And it's a great way to. And then a lot of times these people they've never been to a chiropractor or an and they come in. What do you do here? I said, well, I work on backs and necks and. Well, I got a back problem. So the next thing you know, I've got them on my schedule as a patient. So I've gotten a lot of patients that way too. They find out that you're just regular doctors. They're like everybody else. So it's a great way to build a practice. Honestly, if somebody wanted, I've been doing it so many years, if somebody wanted, I've talked to one of my colleagues there in town, I said, why don't you get certified? Because we can send it to you, because I turn people down all the time. So they need their CDL yesterday. And so anyway, and if anybody's interested, let me know. I can send you all the info. Yeah. And then you have to find a way to kind of market yourself. I did CDLs for years because I had patients that were also truck drivers. Said, can you do my CDL? Oh, sure. So I had done them for years, and then in 2014, you had to get federally certified. So I went
That would only be our hang up. Is that if because we're not federally licensed, so you might be able to do it in the state of Arizona, but if it's a federal license, that would be the only thing that may or may not work for us.
Well, you look into it, because I'm not federally. I mean,
Well,
chiropractors.
chiropractic is they're legal in
Well,
most
we're licensed
states,
state by state.
right? But you're
You're still recognized.
recognized. We're only recognized in 4,
That's
5,
true.
or
But that'd be worth looking into. I did. Yeah. That's why I keep forgetting the questions are a little bit. Anyway, so a lot of things to consider. Oh, TMJ is the biggest. One of my mentors, Dr. Francis, he was like, one thing, he didn't really like doing cranial, but he was always saying all cranials are TMJ and gait, which is hard to argue. It was hard to argue with him about that because he's pretty much right. But he said, fix the gait, fix the TMJ, and you won't have cranials recurring. And that's true to some degree. But there's a lot of cranials that come. A lot of people with chronic food allergies always get cranials. all of us in here have cranials right now, to some degree. We'll find cranials in all. Causes, you name it. Braces, I had braces as a teenager. They paid no attention to my cranials or anything else. They just pulled some teeth and started yanking everything together back in those days. And I know I've had problems ever since from that. I was kind of lucky. I don't have major problems. So malocclusion, if you talk to a dentist, all TMJ problems are malocclusion. Not true. A lot of malocclusion is because the TMJ is off. And if you fix the TMJ, the malocclusion goes away. I see that happen. So if anybody tries to tell you that all TMJ problems have to do with the TMJ, don't know what they're talking about. Motions, strangely enough, I highlighted this because these are kind of the main things we'll be focusing on here. This bit. Birth trauma. My youngest granddaughter came out with she had a flat spot on her head, and fortunately I was around her a lot when she was, and so I did a lot of cranial work on her, and pretty soon it started to kind of pop out. It may have anyway, I don't know, but I would hold her and kind of make it fun and just kind of keep working. It was her parietal bone was kind of mashed, and eventually, I can't even feel it on her head now. It's craniosacral movement. This is, all the other stuff is fun to know, but here's what you guys need to know here on out, and we'll go over this time. This is the motions that the cranial bones go through, and the pelvic bones go through on inspiration. This is on inspiration. Expiration is just the opposite. So what we're going to do is, if you want to stand or stay where you're at, but take your own hands and put them on your own head and start at the occiput. And then find your mastoid processes. Those are key levers that we use for the cranial techniques. And now take one hand and gently lay it against your temple. Take the other hand and press gently forward on the opposite mastoid. Push the mastoid, you push it this way, you can kind of change the vector, but push it forward this way. What do you feel here? Subtle. It almost feels like you're pushing your head, but you're really not. If you read the motion there, now do the other side. Feel just a light contact. This is your listening hand, and this is your pressing hand. And sometimes one side will feel like there's more motion than the other. If you're comfortable sticking your own thumb in your own mouth, press very gently on the midline of your hard palate. And do the same thing. Put your hand here. You should feel just a subtle little movement. That's the cranial bone movement. So when we breathe in, there's a distinct pattern that the bones don't go through. When we breathe in, the temporal bones, which come up to here, the temporal bones flare out. And the mastoids, which are part of the temporal bone, they move back and towards one another. So it's kind of like this. So these move out kind of like the gills of a fish. A fish, when their gills flare and come back. That's on inspiration. The sphenoid, I've got pictures of it. The sphenoid and the occiput move. Have a skeleton?
We don't have.
We don't have. Yeah, we don't. Yeah. But if right here, this is where the basilar portion of the sphenoid attaches. So when we breathe in, this happens.
Oh, you have like 2 slides.
Okay, I'll move that up. I'll go through this and we'll do it that way. So the cruciate suture, which is one I just pushed on the roof of my mouth, it separates on inspiration. The sagittal suture separates on inspiration. Frontal bone, even though it is fused, at one point there's a suture here. It's called the metopic suture. The frontal bone infolds on in-breath and comes back on out-breath. Even though there's a fusion there, there's a flex point there. The sacrum follows the occiput. Now the occiput, because on in-breath the occiput goes this way. The sacrum goes this way. So the occiput and the sacrum go the same way on in-breath. Make sense? So as we breathe in, the occiput does this, the sacrum does this. The ilia are like the temporal bones. The ilia, flare, and the ischial tuberosities move backward and medial like the masseters. So the pelvis is like, the cranium is like a mini-me of the, in that regard. Iliac crest flare, just like the temporal bone. And in general, the whole body, if I'm standing here in Tanasana, for example, as I breathe in, I'll exaggerate, as I breathe in, this happens. I breathe out, this happens. Of course, the sternum lifts as we breathe, so on and so forth. So those are the movements that we want to really get down to do. After a while, we have all these protocols. It's the same thing.
Okay, different.
Is it different?
Yeah.
Oh no. Okay. No, that's inspiration. Yeah,
But it has some different stuff.
Does it?
More stuff.
Okay. So the sacral apex moves anterior on inspiration. The coccyx actually moves posterior, so it actually flexes it that way. So expiration is just the opposite of that. Here's the picture you're talking about. So this is the axis of rotation of, here's the sphenoid and here's the occiput. So inspiration, this happens. So when we're doing, when we do sphenobasilar here, which we're going to learn here pretty soon, we're going to be contacting underneath here. We're actually going to be pressing here and sort of building tension in this mechanism as the patient breathes. I'll explain it all as we get into it. I ran across this the other day. This is a YouTube thing. It's a review video for some exam that these osteopaths take. And it's really good. The guy goes through and he has some great graphics and he talks about the movement of the cranial bones. And so anyway, check that out in your spare time. Yeah, okay, so this, so anyway, once again, here's the basilar junction. This is where the sphenoid attaches to the occiput. Here's your foramen magnum. So what's happening right there at that, where basically your brain stem is coming right through there. There's this little kind of pumping thing going on. Unless we're locked like this. Then, of course, we're not moving, right? So this right here is, I mean, my cranial, if I see somebody walk in like this, I'm like, because I know their craniosacral mechanism is just locked up. And I don't know if I never really know if I can have much effect. These are all the different cranial faults that we'll learn about and we'll learn how to fix. We'll learn this one and this one this weekend. We'll learn this one, and then we'll learn the rest as we go. These are the big. This one here and this one are probably the two. Well, and this glabellar fault. They're probably the ones I use. Well, I use saturated suture a lot. I probably use these two the most. I probably use them on every third patient. The stomach break. So we separate them. Am I blocking you? I keep thinking. We separate them into these different categories. The flexion extension ones mainly have to do with the sphenoid and the occiput. The sutural ones are all more out in the various sutures. So any of these sutures can get locked up. Sutures are basically, they're sort of a primitive joint. They move, but they're not like a synovial joint. Much less sophisticated. But they can get locked, they can get jammed. One of the most common jamming things we see with sutures is the temporal and the parietal bone gets jammed. And a lot of that has to do with TMJ stuff or falls, gets boxing. Oh, anyway, because when he was talking to me about his history of boxing, I think, there he is. Okay. We're just talking about cranials. One of the things that often is hits, blows his head. Car wrecks, so on and so forth. Then the rotational faults, and these are where this, instead of the sphenoid and occiput getting stuck and not being able to do this, they'll be kind of like, they can get like this, or they can get torsion like that. These get pretty weird, and they can be very difficult to fix sometimes, but we'll do our best. These are the ones we'll learn this weekend. So in craniosacral, the classic craniosacral approach in SOT, most of their corrections are direct. They know which way the bones are supposed to move, and they'll kind of feel for movement. And then if they don't feel it, they'll start guiding them. And pretty soon the bone, they'll kind of feel the rhythm, and they'll try to get the bones moving again. And it's very well. It's very slow. It can be very slow. In Dr. Goodhart and all his cohorts back in the day, they started experimenting with rebound corrections. And rebound correction is kind of like a rebound challenge. You're basically going against the normal function of any given bone. The idea is you're building this tension and getting the cranial fault to sort of dissipate on itself. So AK is the only approach that uses rebound versus direct. Except for some of our corrections are direct, like the sagittal correction is direct. All of the sutural corrections are direct, but the flexion extension, the biggies that we are rebound. So kids, it's believed, don't have a rebound phenomenon in their spine or in their cranium. And I believe that's true. I don't test kids under 6 or 7 or 8. I've had a few kids that I test a little younger, but it's kind of fun. I've had a lot of kids that I've tested since they were little. I used to surrogate test them with one of their parents, and now I can test them. I mean, I've got one patient. He's got 2 kids. He's an engineer, somewhere in his 30s, married. I met his mother when she was pregnant with him. She's still a patient. Saw her a couple weeks ago. And now he and his wife and one of their kids has been patient. So that makes me feel really old. But kids are hard to muscle test. But when they get about 7 or 8, they start to get it. Unless they're my granddaughters. I've been testing them since they were probably 5. Cruciate suture, this is the one that seems to really be impacted by dental stuff a lot. Cases especially, spike splints, these kind of. This will be the first one we'll learn, but we're going to first, these are well, we're not gonna get into this one yet. First, I wanna do a little experiment where we kind of get into feeling. Did this last year. I want you to all experience each other's heads. Not inside your patient's heads, but outside. So kind of get the idea, get the feel. So let's do a workshop where you pair up and one person's going to lay down and the other person's going to get out their heads and you're going to put underneath their occiput and you're just going to keep it there. So I'll kind of talk with you the rest.
I mean, like, how to keep ready to be done. Ready to be done. So you push on the ground. I'm excited to see
When you get in position, I want you to stop talking. Okay? Please. Talk until you get, when you get in position, stop talking. Oh, stop talking when you get in position. You're going. Back, let's even. Okay, so first thing you can do is you're going to put your hands on the back of your head. I want your patient to close their eyes. And unless they need to tell you something or you need to tell them something, don't talk. Just feel. In fact, as the examiner, it's really helpful to close your eyes too, and cut out the external, stimuli, and really tune in to your hands, what your hands are hearing, feeling, sensing. And you remember last session we did that little exercise where we held our hands and we felt the electromagnetic energy. That's really helpful. If you're having trouble tuning in sometimes, if you just take your hands and just hold that, breathe in a few times, and being aware that your aura, your electromagnetic field, which is especially strong in your hands, is now intermingling with their electromagnetic. So before we start doing anything with their actual tissue, we want to realize that we are energetically connected. We're listening. Our hands are listening. You're, as the examiner, if you're not breathing, breathe. You as a patient aren't breathing. Allow yourself to breathe. As the examiner, make sure you're comfortable and relaxed and receptive. Now, gradually bring your fingertips up against the back of the mastoid processes on your patient's skull. And lightly palpate. See if you can feel that suture. You kind of feel that kind of groove in there between the mastoid and the western temporal bone. Now, go ahead and with fingertips up against the mastoids, gently press one forward at a time. Do that 2 or 3. See if you can get a sense of the give. Go to the other side. And if you can feel the give, feel it out, maybe neither one of them. Whatever it is, just follow that information. Now, I want you to gravitate your hands up to just above the ears, along the upper part of the TMJ muscles, on the junction between the temporal lobe. So, if you kind of visualize that picture or your memory of anatomy, just lightly use the pads of your finger to trace out that. Now you'll be feeling through the upper part of the temporalis muscle. So you'll feel the muscle crosses just over that suture a little bit, goes into the fascia just above that suture. And while you're feeling, if you feel for any differences, maybe one side feels more prominent, opy, whatever comes into your hands. And gradually move up forward towards the front of the head till your fingers up against the orbital ridge, I believe it's called. Like a bony ridge that's mostly vertical. Your fingertips will come up as you move. And when you find that orbital ridge, if you let your fingertips drop back just a hair, it goes into the temporal, into the, what you're touching is the greater lingus. Part of the sphenoid that comes out to the side of the skull. Remember the sphenoid, which is the keystone of the skull. The sphenoid is what houses the pituitary. So the pituitary gland is sitting there in this nice pocket, sella turcica, and is slowly riding back and forth as these cranial bones. Pineal, which sits farther back, of course, is also being sort of massaged and waved through with the cranial motion. Pineal, which is considered the sixth chakra, that centers around. So, lastly, before we switch, let your finger pads move down over the TMJ. Now, it's going to be, if you have trouble finding it, it's going to be directly in front of the external auditory meatus. And they have them just open their jaw and close it a few times. And when that happens, you can really tell where. Now, the condyle of the jaw, the condyle will kind of, the condyles, as the jaw opens, will feel like they're sort of coming out into your fingertips. without going out. And a lot of times, when you know you have a TMJ issue, is one side will kind of, on the other side isn't moving. Once again, make sure your patient's breathing and make sure you're breathing. Might not be a good idea to do right after lunch. So as you're ready, we'll switch.
She wants it to stop.
So, so once again, once you get kind of settled in, let's all the examiners and examinees, just for a half a minute or so, bring your hands together. Close your eyes and check in with your breath. Make sure you're breathing. And then pull your palms apart just a little bit. Feel the warmth. At first you feel the warmth of each palm together. And hopefully you'll feel this sort of electromagnetic sensation. Move your palms a little further apart, you'll feel it maintained. You can get inches away and still feel this. It's like a weak magnet. Like you take two weak magnets and push the the two positive or two negative poles together, you'll get that repulsion. And then at some point you'll feel almost like a polarity switch as it comes back and forth. Everybody feel that? Everybody not feel that? To some degree. Some of you. This is really crucial. I do this every morning before I start. Sure I have some brain is connected with my hands. My energy's pretty weak, and I got to do some things to get my chi up. So when you're ready, go ahead and make sure your patient has their eyes closed. Make sure they're breathing. Make sure you're breathing. And if it helps, close your eyes and bring your hands underneath their occiput. Just leave them there for a bit and let your patient relax into your hands. This can sometimes be the most effective thing. This might be as much as they can. Now, you bring your fingertips down and against the back of the Now, if you put a little bit of pressure against the mastoids and your patient is breathing, you may feel those mastoids move. It's a subtle movement. You may feel them move back and together. You may also get a sense of the occiput moving. Remember, the occiput, on the in-breath, the occiput rolls under, like it. Mastoids move back, and the occiput moves. Then if you bring your fingertips around, feel that sulcus there between the mastoids and the occiput on the back of the mastoids, and bring your fingertips up over above the ear. Look for that temporoparietal suture. Feel along the temporalis muscles are catching. Outpatient is something you never, ever quit learning more. Moving along just above the ear, feel those. If you can really feel that suture. Parietal bones will sometimes jam down on the temporal bone. Parietal bone and the temporal bone will sometimes bulge. Common. As you work forward along that suture, at some point you'll come up against the upper part of the ridge. That's the kind of the area we were feeling with our listening hand when we were pushing on our own. Fingertips drop back, and you're right over the greater wing. Now, drop those finger pads, those listening finger pads down over the TMJ area. And lighter is better. Lighter is the lightest you can contact is usually the best. Have them open their jaw slowly and close it. Feel translation of that condyle. I'm sorry, the condyle on TMJ. You're right on it, you'll feel condyles move lateral slightly as the jaw opens. Maybe one moves and the other one doesn't feel. So, that's changed it. So I'm going to show how to push a suture. And then I'm going to show you several of the sutural faults to check for. Then we'll team up again. And I have a feeling we'll probably find, always do, we always love it. If not, I always have some.
Good job.
Yeah.
You don't want it. I felt like I'm so anxious and she wants to know. Yeah,
It's almost like
I don't think you still feel it.
I just like remember not. I feel my own so
Sure.
Guys, are we ready? So one thing I didn't have on the slide for some reason is the signature test at AK for whether you have a cranium or not is a weak muscle will strengthen on a breath in or breath out. It'll strengthen. Muscles will change strength either on inspiration or expiration. So it could be different ways, but normally when you're testing muscle, it shouldn't change whether the patient's breathing or not. It shouldn't change if everything's balanced out. So the cruciate suture is a little harder to ferret out that way. The ones that really respond to that test are inspiration assist and the spheno based. But I'm going to look for a weak muscle. So far we haven't. We know we have some psoas, right? What am I testing? What did you say? Scalenes. SCM is full flexion, full rotation. And scalenes is 30 degrees flexion, about 20, 30 degrees rotation. Depending on, as a group. What am I testing? For last session?
Which pattern test?
Once again, anyone? Pectoralis major. Ah, thank you. Okay. Shout it out. Okay. What am I testing? Pectoralis sternum. Everybody got that, right? So clavicular is this vector, sternal is this way. Bats, yes. See. Fantastic. Latissimus dorsi. Thank goodness. Now, who knows what innervates the latissimus dorsi? Is it lumbar? Pelvis? Thoracic? Neck. It's innervated by the cervix. It's innervated by the brachial plexus and anchors clear into the SI. There's actually fascial connections clear down into the sacrum. So the neck problem can affect the pelvis. So this lat right here, both lats are weak. So I'm going to ask you to take a deep breath in, hold your breath, and you guys see what happens? Breathe in. Turns that muscle on, just like that. I got lucky. Breathe out. So that is a test for a inspiration assist. That's the most basic cranial level. That's where we're going to be pushing on the masters. Now we want to see if she also has a cruciate. Dr. Leaf used to say, probably still would if he was still walking the earth, but Dr. Leaf would say that everyone, if you have a cranial, everyone's got a cruciate. He would always start with the cruciate suture. He would make sure it was open, and then he would go to the others. So he was the kind of guy that. Put your left thumb. Okay, so I'm not going to use that away. Now I'm going to go back to a strong indicator muscle because that was we started with a weak. So now touch your cruciate suture. Breathe in. And do that. So she TLs. Okay, so a strong indicator muscle, which is strong in the clear, nothing wrong with it, weakens to TL to the cruciate suture. Now, when she breathes in, that negates the weakness. So that tells me it's going to need separated. They always need separated, but theoretically, a cruciate suture can need pushed back together. But I don't think I ever see it. But theoretically, it could. So I'm going to correct her cruciate suture first. So do we have enough gloves? So we've got lots of gloves.
You guys can come closer if you'd like to see this. Sorry.
Extra long.
This one.
Hands aren't that big, but identify this.
Don't worry about me.
Okay, thank you, sorry.
Okay, so everybody knows where the cruciate suture is, I assume, from gross anatomy, but you want to be at the head of the table with both this and the inspiration system. And I'm going to take my two long fingers And I'm gonna press and then go back and find just the beginning of her soft palate, and then I'm gonna bring my fingers forward till I'm about in the middle of the suture. Relax your jaw. Be sure their jaw isn't stressing. You see my fingers here? Put these two fingers together and my thumbs together, and then I'm gonna use these to stabilize, and these fingers are gonna be doing this as she breathes in. Now you can do it a different way, that's fine, but this just feels really stable to me and really stable to the patient. I'm, as she's breathing in, I'm separating, like this. Okay, relax your jaw, breathe in. As she breathes in, I press hard. Let's do that a couple times. And I'm right in the middle. Good. Now I'm going to go back to the beginning of that suture, close to where the soft palate starts, and then we breathe in. Go ahead. Now come forward. Sorry. You actually had a fixation there. Middle one felt, yeah. Now I'm coming forward to the middle again, so breathe in again. And then we're coming right to the, make sure you're not on the teeth. I want to stress the teeth. Breathe in again.
Working your way up.
I am. There we go. Whew. So she needed that. That's good. And for CTL, just like that. Only inspiration. Yes, and with this suture, that never happened. But theoretically, it could. I mean, but it never does. I mean, it just doesn't. It's just like the sagittal suture. It only jams this. It never gets, unless there's been a big trauma and it gets dropped in the head, then it could. But I mean, most of the time it's jammed this way. But it affects you. We'll talk about that. And these two here, and then I press. It's like this. We don't have a skull in here. But it's about that much movement. But it's that direction. I'm pressing up just enough to get a little traction, and then that's a really, when you do these, people will like chill out. It's like, it's really relaxing. It promotes parasympathetic. What's the pressure you put on? I would say 2 to 4 pounds. I don't know. It's not a lot. I mean, if we have enough gloves, I could do this on every one of these things. Let's see if that understands. Now, what did we start with? Remember, what was the presenting issue? Bilateral weak flats. And then she TL'd the strong indicator muscle, TL'd to the cruciate. So. Ooh, baby. I mean, this is really powerful work, I'm telling you. Now, TL that cruciate. You know, I'll make sure that I'm not missing anything. That clear. And I could feel it move. You can feel it. Lean back, please. Remember this morning you had a bilateral psoas weakness.
That's bilateral.
Was that you? Bilateral?
Wait,
Who had the
no.
bilateral psoas? You had
You're fine. Yeah.
Spinobase, which we haven't checked. Okay. So, but we had this, didn't we?
Have that.
Pull in. We still have it. Okay, now breathe in again. Now, Now this time you're gonna breathe in all the way as much as you can, like a forced inspiration. Oh. There it is. So that's the next step, and that's a stenobasis. Should we fix that now, or let's not? Let's hang. Let me stay on track. Let's do this. I want everybody to lay down. I'm going to get a bunch of gloves. I'm going to do this on every one of you. We won't do this on every cranial, but that way you can feel the pressure, and you can. Once you feel it, I don't have to talk. Right? Once you've experienced it. So.
Well, I think it was a little bit confusing because he did a weak muscle and then he quickly switched to a strong muscle.
I don't know, just every time like
When he does like when he switches to just like
Actually, you know what, Dr. Whitney?
Yeah.
You want to do, you do this one all the time.
I do not.
Oh, you don't?
I mean, I can, but I don't do it all the time.
Okay. But you've done it.
Yeah.
You know what it's supposed to feel like.
Mhm.
If you want, you can grab some gloves.
Or you're just showing them the pressure to use,
I'm just doing the correction.
but they don't have it.
Well, it's not gonna hurt them. I want them to feel how much pressure I use.
Okay.
Okay, everybody, yeah. So I'm just gonna go from person to person. So if you wanna watch, that's fine. Okay, so here we go. Little fingers. Now relax your jaw. Now see, I brace these here. Make sure their jaw is relaxed, so that they're not cranking their jaw. Okay? Breathe in deep. I'll just do a couple there so you feel the breathe. That one is a little tight. Ooh, there it is. Ooh. Okay. Okay. So that was. Okay. Okay, so we can just use this table. Somebody, that way I don't have to move around as much. Yeah, yeah. Okay, so once again, go in there first. Now you also can feel their cruciate ridge, or that where the cruciate, typically the cruciate bone should be like that, right? Well, sometimes they're like this, and some of us have that kind of ridge in there. There's lots of different theories that has to do with, the wrong diet when we're developing or something, but our jaws get crowded. You have just a little bit of a ridge there. Breathe in. And there you go. Good. More than you expected. So when you so when someone's working on you, you kind of know how it should probably feel. Right? That's the whole idea.
Oh, I'm in the
So
camera.
do you find appreciated what jam on forced inspiration? That's no.
You could, but forced inspiration is going to reveal a stenobasis. Regular inspiration is going to reveal just simply an inspiration or expiration, which is much rarer. Where you take a breath and the muscle strengthens. That's an inspiration.
Versus like what you had heard or what Lucy when she said, like
That was a forced inspiration, and that revealed the stenobasis. But we kind of knew that from this morning when we were, and the sphenobaseler goes along with the cathexins, which she also has often.
How do you find a cruciate?
The cruciate will be, it'll be indicated if it strengthens on inspiration. And then you TL it. So a weak muscle will strengthen on a breath in. And then you go to strong indicator muscle, and you know it's either an inspiration assist or a cruciate, or maybe, and then you have them TL it. Now, if it doesn't TL, then you go to the master and usually
So is it typically more cruciate or masculine?
cruciates I find inspiration assist I found. Phenobaselers I find every day. That's an inspiration assist. Now, if we take, like, say, we'll use this here. What am I testing? From the head of the table instead of standing? Okay, breathe in. Breathe out. Now in through your nose. She's got something else. She's got something different. That's okay. I'm going to do this, the cruciate anyway. So you can feel it. Yeah. You got something different that we won't even do this section. Okay. An outlier.
So I guess I'm kind of confused what you mean inspiration assist. I know that's a way of adjusting. But do you need something else?
That actually needs it to. There we go. Yeah, that was good.
It is more pressure than I thought though.
Yeah, that's why I wanted to do this. Now, breathe in. Breathe out. Hold it out. Actually, that kind of cleared it. That cleared it. Okay. You got more going on.
I know.
Yeah.
Okay.
All right, next.
Are you getting the for that muscle of fire also? So if there's
Sometimes you'll feel you'll need to kind of do a little bit. Good job. Sometimes I'll feel them and I'll actually do kind of a little bit of shearing motion, raising it back. That's just something from doing hundreds and hundreds of it.
And so if it gets the mechanism of so now
I'm telling you, this work is really powerful, and not a lot of people do it anymore. Most people don't have the patience to do it. It takes a lot of patience.
can't replay.
Breathe in.
Shuts it down. And now everything's like, oh, we still got a punch.
You go over the shit there. Woo. You feel that's about that much.
Yeah.
His actions moved a little bit. You have braces?
I did.
Yeah. This help, everybody who I've done this on before, hopefully this it'll be worth taking the time to do.
And you'll be.
And
Everything like wise,
a little bit of ridge. And breathe in. you could feel that much pressure. It was kind of, several of you have said it's kind of more than you thought. I don't want to grab it because then I contaminate the glove. You have a little more. She has a little more of a ridge than the rest of you. So. And
So
there we go. I was a little harder than because I had. Okay.
yeah, okay.
Yeah. So you have that thing where your cruciate is kind of like this. It's pretty common. I've felt some that's like that. It's amazing. Next.
Go.
What file here? What's that? Yeah. Nice if we can do something. We can blow them all up. Paste them around the walls. You got a little bit of ridge too. Where did you grow up? Nebraska. I don't know. Where are you? Michigan. Midwestern. Maybe there's something to that. More rich. Sort of the goiter belt.
It doesn't mean it's not still. You still have an athletic right? Like that.
Now, when I do the single base work, when we learn how to do that, it's about the same amount of pressure I use. I'm pressing on either side of the
true.
Some people
This one, like the soft palate, here, like the soft palate, things like British and
I was on.
it's like the soft palate, like in the back, and then you have the British, hard palate.
It was along the side of it. See, some people, the whole. The cruciate's there either way, but sometimes you don't really feel the suture so much. The ridge means that the cruciate hasn't, it isn't meshed like this. It's sort of doing this thing. That's also you got a little bit of a ridge. Now, so that's. I say victim.
Volunteer.
I needed that. I'm like a new person right now. I think that's a
It's better. Actually.
I feel like Brandon.
You got a nice.
I was gonna say go run a marathon, but I would probably die. But I am ready. Yeah, I know. I have one this morning that killed me. I'm blaming why my abs were like all that. Yeah.
It was a lot.
You know?
But
I appreciate that.
you're kind of tight in there, and you have a bit of.
Right. I went to Pilates.
That would be a good thing. Maybe you guys work on so that you can go, maybe just go more often, lighter. Because I see people like once a month.
Yeah.
You can.
I like that.
Yeah.
That's really good. I would
Next. I just keep remembering that I had all that garlic sauce. Seemed like a good idea.
I think like a good amount of I think it's an everything related thing. I've heard escalated, I've heard I think we all just have to mind you know. Yes. Oh yeah, no, mine's what is it? Yeah, really? He didn't tell me anything about mine. Oh. He didn't have anything to say about it. And I feel left out. I'm you, but I'm also no.
Okay.
Not even that.
Why don't you guys, I've already pushed on your jaw, your roof of your mouth. If those of you are done, if you want, you can start teaming up, looking for a weak mark on each other. See, go through and go back to last session, check the delts, check the upper trap, and check the lats, and just kind of make note of the weak muscles and then switch to do the same. So then when I get down here, then we can start checking those weak muscles. Everybody's got that.
I love that. Yeah.
She put her whole body into it.
It's because he's strong.
Make him weak. Come on.
Shoulder hard enough.
Sit out on the thing. Give her a fair shot. I got it. Yeah. Guilty. Yeah, I believe that. Yeah. It's always around this time. We have
It's like the weird
an hour
time.
and a half left.
Because I think lunch, like everyone, like,
We lose it.
yeah. And then everyone's, oh.
All the way on the east side. I don't even know. I don't agree with what they consider.
You're a bit tight in there.
You know what I
That
mean?
would be good.
Take it up with
Like,
them.
I know I am. But like, how is the Midwest like Michigan?
That's the Mideast.
That's what I'm saying. Thank you. The Midwest is like Canada.
Oh, yeah.
But no, nothing so. Are you asking me something? I don't know. Where is it? Do you have the correct answer?
Yeah.
Oh, I don't know anything on that. Yeah, me neither.
Oh,
My fingers at the ready.
Oh, I'm the fingers already.
Okay.
It's starting to get sore.
Getting a in today. Okay.
His middle finger rubs in today.
When he, on the way home when he's ready. I don't know what picture. Mine's
Yeah,
I need to sleep tomorrow, but he's in his own world. He's gonna kick in his feet like dumb. I said, he might agree. I don't know. No, yeah, now he needs to know. You're on your own. You're the one that said it.
No worries.
Fifth on that.
Nice flat, nice smooth flat. Mark out, relax your jaw.
That's the West Coast.
West Coast.
Do you know what I'm saying? So, like, I think it sticks out.
What's that?
Stop! She would laugh. No, are you kidding me?
Right, you're up.
I feel like not that that's happened.
Means you need more rest. Nice wide palate.
She's the last one. Get ready to get your life changed. Open up.
Nice wide.
You have very good my like top piece like bowing. Okay, barely. Okay. Oh, shut up. They're there. They work. That's not. I'm sorry for complaining now. Do you want yours, son? You want yours, son?
No, I didn't know if that was
Let's go ask. I don't know.
I would actually. Yeah. That was an interesting one.
She was holding her breath.
It was still strong. I feel like it was like.
Hey, guys. Guys, so you guys have all found some weak muscles by now. Remember, if you're the patient, remember which muscles you had weak. If you're the examiner, remember which muscles you not weak on them. Between the two of you, you should have a pretty good recall. Because we want to go back to those in a little bit. But I want to show you on Dean. Come forward.
Let's go, Dean.
Now, do you guys remember this morning? Sit here, please. What am I testing? What am I testing? Rectus abdominis, right? Now, he's not too bad. If we crowd him a little bit and have him straighten his, he's kind of lunging forward to keep your knees together. And then he loses it. Now, when this particular muscle is weak, he's pretty good in neutral, but if we take him out of that, we lose it. So that's a little stronger. Let's go all the way this way. It's not too bad. Maybe you're not as, not there, that's, okay. So I'm gonna go with this one. His left rectus, I'm gonna focus on that. A little bit of arch. Okay, so that's, yeah. Now then we arch this way. There you go. So that's weak. Now, breathe in through your nose. See the difference? Okay, breathe in through your nose, even with him arched. Breathe in. Okay. That totally negates the weakness of that muscle. Now, the classic this for that with abdominal rectus abdominis is the sagittal suture, which is the one we're going to learn next. The sagittal suture is this one right here on the top of the noggin. So, do we know that that's what it is? The way we tell, there's two ways. One is I could take a strong indicator muscle. We'll see how the delta is. Good. Now breathe in. Breathe out. So he doesn't show cranials in the clear. I mean, if a muscle is only strong when someone's breathing in, that means there's definitely cranials. But this is, we have to dig for this. But we know that his abdominals are weak. So go ahead and touch with your other hand. So we're going to therapy localize the sagittal suture and the weakness. And sometimes, yeah, I'll have you kind of use 3 fingers and get right on that back. Now have him breathe in. Oh, and he turns back on. So he strengthens with a breath in. They always do. The cruciate and the sagittal pretty much always are going to be strengthened by inspiration, and they're going to need to separate. Theoretically, you could have the opposite, right?
99.
99.9, yeah. So the other thing we could do is we could use the original weak muscle, which was the rectus abdominalis. And now, I want you to breathe in, hold your breath, which we already did. So that is verified by the strong indicator muscle weakening. So I'm going to correct it. Face that way for me. So the sagittal suture, and we have a bunch of slides on it. The sagittal suture, remember the frontal bone comes clear up to about here. And that's the, what do they call that, the anterior, the bregma, anterior fontanelle. So that's, a lot of times, his is fairly prominent, so I can kind of tell right where those parietal bones meet. So the sagittal suture is where the 2 parietal bones meet into. So I'm going to press like this, just like it was on the cruciate suture, like this. It's going to be like this on his sagittal suture. As you breathe in, breathe in. There we go. And again. Now, I've done enough of these that I kind of can tell. At first, a lot of times there's not much movement, but as they breathe, they'll start to feel some flex. His needs not just this, it needs some of this. Okay. And make sure they're breathing fully, and make sure you're working with their breath. A lot of times we get in a hurry and we get ahead of ourselves. Their body really kind of directs the therapy. That's really moving now. You feel that? Feel that move? Behind your eye. Breathe in again. And let it go. Now you've had head injuries. Bad car wreck. Breathe in again.
Shouldn't have to label it that way.
One more time. Oh, baby. So now in my office, I have percussors. I have a couple of percussors, and I will often use a percussor on the upper back. I'm doing cranial. Sometimes I'll just kind of prop it up there and I'll do that. I'll use it when the patient's high, and sometimes I'll come up and use it, turn down way low, and I'll use it. I use it a lot to help speed up cranials. But maybe sometime if one of you, I don't know if anybody has percussors around here. Do you have a percussor?
One in my bag.
You have one in your bag? Cool.
Put it right on my forehead every morning.
Do you?
Why am I nuts?
No, that's not a professor. We're talking about an
Activate.
activator.
Oh, no, I'm talking about the.
I mean, I use like a gun, but it's not an actual professor.
Remember, the knees need to be together. And right there, a little bit of arch. We want to weaken it. See, I can't do it. So that's much better. Now, did he cheat? Did he hold his breath? Breathe in, breathe out, breath out. No, he should be strong on the breath out, and he is. Breathe in, breathe out. Yeah, strong like a bull. Not weak as a kid, strong as a bull. So that's the sagittal suture, and it's often found. In fact, I will always find it with rectus abdominal muscle weakness. The thing is, often it isn't the only thing. So you'll correct it. A lot of times the muscles will turn back on, but there's often a lot of other things to look at. Thank you. Thanks for bringing that in. That was a problem. Yeah, TL.
I'm not like
You could. It's a little awkward if you can. Dean, come back. That's a good question. Sorry. Yeah, that's so. Simply says, Michaela asks, couldn't we TL when we're doing the test? And we can, but it's a little awkward with this. But you can do it. So this way. Now you get you in a position. Then you take one of the hands. Yell it. Thing is about this is you're introducing more potential factors. Now he's not weak now because he's fixed, but every time you move a hand to TL, you're affecting the joints of that arm. So you're adding more factors. So you always want to think about that. There's a lot of things you can do, but are you adding more factors that might muddle your? Thank you. Sagittal suture. Anybody else have a question on that before we workshop that? Because I'm thinking we should just workshop that one. Where are we at time-wise?
3:07.
What time we quit?
4:30.
Yeah, I think we can get through all this again. Let's. So did anybody, when you guys were testing a little bit ago, did anybody find weak abdominals? Anybody test it? You had some?
I have weak abdominals.
Come forth, please. I want to do one more of these. Okay, so sit here facing this way. So I'm going to do the same thing we did with D. Oh, yeah. Okay. Okay, this way. Yeah. So you're right. Okay. Now, what do I have him do at this point? There's two things we want to find out about. One is, does he have a sagittal suture? I've just been going on about it. Secondly, or before that, does breathing in negate the weakness? Does it abolish the weakness? So those are two things we want to find out. So here, breathe in, hold your breath, and that does make a difference. Breathe out, stretch back. There you go. Try it. Yeah. Now breathe in, hold your breath, and it does make a difference. Breathe out. Let's see if on this side too. Breathe in. Big breath in. Okay, breathe out. Big breath in. Yeah, so he has an inspiration assist. Does he have a sagittal? Let's see if we can find it. Oh, relax. See if we can find a TL. Now that's a little spongy. Yeah, that deltoid is just a little spongy. That was better. Breathe in. Breathe out. Now making sure that he doesn't have a breath in or out affecting that muscle, and he doesn't. To touch your sagittal suture. And it's there. He's really strong with it. Now, I'll have you breathe in. Deep breath in. Hold your breath. Okay, so that worked. I hope it will make your hand right. So I'm going to separate his sagittal suture on a breath in. It's a direct correction. So again, I find his frontal bones. Sometimes people's frontal bones come back further than you think. His is right there. And then breathe in. Let it go. And again. This way, when you have your colleagues doing this on you, you can tell about how much pressure I think is appropriate. Okay. Do it again. He's got a sphenobaseler too, I'm pretty sure of that. This was the strong over there. PLU. You need there in your center. Do that one. Yeah, okay, so that cleared that. Let's see what it is we don't. Right there. Just breathe normally, in and out. Okay. That's way better. That's way better. That's way better. Yeah, I don't, yeah. Breathe in and breathe out. Even on the exhale, I can't do it. I'm not paid. That's I'm breaking the sweat. What kind of, would depend on the kind of neurological issues.
Like, let's say they have like MS or something, would you not want to touch that?
Oh, yeah, I would touch them. I would, yeah, I mean, I would do, I've done lots of cranials on people. I mean, not a ton of MS patients, but I've had a few over the years. I'm not treating their MS, but, now, if they had something really wacky, I mean,
Not like a brain abscess. There's not like an active.
oh, if they're sick, they got a sinus infection. I'm not doing it. No, go home. Get out of here. Yeah, recent brain injury. I'm going to be very, very careful. I have a trauma. Not sure how to answer that.
Use your
If they had,
clinical
like,
judgment, your risk tolerance, and like within your scope. Like if you adjusted it and something went wrong, and you cleaned it up.
You hide it.
Well, no, but like, sometimes you fix something and then it kind of unravels some things. Like, can you do that, right? Or are you gonna do something and be like, oh, now you need to go to the ER, right? That's not a position you'll be in. So.
These corrections are pretty gentle. You're not, these are way different. Now, I would be way more cautious about adjusting someone's upper cervical. If they came in to me dizzy, I'm gonna do all kinds of stuff to see where they're at before I attempt to adjust. But cranials, I might do some simple.
But they're like generally safe.
Yeah, oh, very safe. And like any of the respiratory corrections they're really safe. That's why I like to really emphasize those.
What about like individuals with like concussion or prior concussions?
That's where a lot of times this work really shines. I do a lot of work with athletes that have good times. Now, sometimes I have really good results, sometimes I don't. And I've worked on people with real severe AD, parents pregnant, and my results are kind of mixed. I get real amazing results, and then a lot of them are hard to do. A lot of times there's a lot more going on. MS is something you run into, I guarantee, and you also run into Parkinson's a lot. Parkinson's, in real extreme cases, if they're breaking. But like Dr. Whitney says, it's like case by case. But you're much safer doing this than you are any other kind of physical medicine. Let's see if that helped. See if all this was just a waste of time. Just temporary. Smoke the mirrors. Hold there. Breathe out. This guy, that's really different. But there's still something going on. You see what he does with his head? He always wants his head Just like that. A little more. There you go. That's still good. I would actually, I think you need probably some work, maybe some yoga or Pilates or something that could kind of help free this up. You've been kind of here for a while. Does that make sense? Thanks. Sagittal suture. Yeah, that's all we did. So, we could go on with sagittal suture. So this for that. Take it to the bank. It's probably a 67%.
I just brought up the sagittal.
Thank you.
since
Yeah.
We're talking about it.
Since we come. So anyway, these marks are, you're not going to be that fast clear up on the frontal bone, but you get the idea. You could even be safe if you were like in clinic or if you're working with people. If you just did a basic cruciate separation and a sagittal separation on everybody, it would probably help, probably clear some stuff. It's one of the ways that the body kind of contracts and walks out. Just motion in it. Sometimes when you do cranials, that's why it's always nice to kind of screen for motion. Sometimes when you do cranials, people will start to have some really emotional release. And if you're already behind, that can be problematic. I love it. I love it when if somebody breaks into tears, to me, that's like, okay, we got it. But I want to be able to be there until they kind of, and sometimes they do it, you're already kind of behind, and then it's like, cat's out of the bag, and, oh man.
That's
So-
the last slide, so you're good. Go the other way.
That's the last one. Really?
Well, because sagittal's at the very end. It wasn't after cruciate.
Thank you.
That's why.
Okay. That's right, I had it, yeah. So what I'd like to do, how much time do we have now?
Now,
An hour? Okay. Oh, one more thing before you guys can layer one more thing. Somebody had this. Somebody who strengthened on inspiration with their psoas. Is that you? Is that you? Would you mind coming up?
or not you.
So, actually sit first. So, remember the occiput, if I'm standing like this and I breathe in, my occiput does this. What does my sacrum do? Same thing. Now, a lot of times, if there's lower extremity weaknesses, they'll respond more to what's going on with because remember, it's craniosacral. So, if you find anything up here, there's going to probably be something going on here that might need to be. One of them, who was it? It was somebody with hamstrings this morning. Was that you?
I thought mine was a cat too.
I think it was, but I think you strengthened on inspiration. Or was that Alyssa?
She did, but she has a cat too, but it strengthened on breath in too. And a sphenovalular, yeah.
Right. Late face cam. Pull off your glasses. Let's see.
Can you start writing it down?
Is that?
Can you start writing it down?
I think
So
so,
that we
yeah.
don't have, so we know how to go back to.
We don't have chart lines. Charting. Okay, so I don't know. We'll see if you have this. So what am I testing? Hamstrings. Am I testing all the hamstrings? Okay, what am I testing now? What am I testing here? So lateral, medial. All is a group. Just a little bit. And you want to be a little less than 90. That's pretty good. And I tested her a bunch of times, so yes.
When you are testing hamstrings, is that in the adductor magnus and says two heads, or is that grouped in?
That's grouped into the adductors. Now, that doesn't mean you won't cause some firing of the head. But they really don't have, if your vector is good, you're gonna pretty much isolate hamstring. If you're ever in doubt and you're thinking, well, just go in and start stimulating. I mean, yeah.
I just didn't know, because I was a hamstring head and an adductor head.
Now these are strong, so I'm not sure she has this. She might have a sort of a subclinical or sub. Now you're just pretty darn good. Let's see what's going on here. Hold that. That's not too good. Okay, there we go. So bilateral, what am I testing there from last section? Good max, right? Deep breath in. Hold your breath, hold the muscle. Oh yeah, there we go. I've been lucky today. Breathe in. Hold the breath, hold the muscle. There we go. So I can challenge the sacrum with a dynamic challenge. Let's see, I lost it. Oops, okay.
Yeah.
Challenge, challenge, challenge. Oh. No. Challenge, challenge, challenge. Okay, so she actually is stuck in flexion. So I'm pushing her into extension. So challenge, I'm going to do it again. Yeah. Okay, now I'm going to do a static challenge the other way. And yeah, she's really strong. There we go. Yeah, so if I shout, see, it's in lesion that way. So she needs an expiration assist sacrum. Normally it's inspiration assist, but every so often there's an expiration assist. You need an expiration assist. Okay. So I'm going to do, so it's a direct correction, just like the cruciates. Breathe in, breathe out. I'm following the normal way that the sacrum goes. Breathe in, goes like that, and then on the exhale, I'm following it down. One more time. And let it go. Hold that again. Shut. Okay, now try this again. These are probably 80%ers too. Now breathe in, hold your breath, breathe out, hold your breath out. Yeah, so she's good either way. I could test that a little bit. So does that make sense? She happened to have a sacral fault, but it happened to be an expiration assist. They're kind of rare. But she's from the Northwest, so we're all kind of tweaked up there. It's kind of like we live in Middle Earth this time of year, right? We've got, it's so beautiful and mystical, and the weather's really kind of cold and nasty, and it's just beautiful there. Fog. And
Cold and nasty.
It is, it's really, it rains sideways and blows about 40 degrees, but somehow it's a certain charm. Okay, so.
Go back.
Oh, yeah.
Go back. Do you want me to probably go further up? I know
So I'm going to go to sphenobasis. I'm going to, you guys, I think Dr. Whitney has a sphenobasis. So I'll present that one last, and then you guys will start chasing down your weak muscles. So when I first started this discussion, we were talking about how the occiput and the sphenoid invest on inspiration. This will usually only show with a forced inspiration or a forced expiration. Normal inspiration or expiration a lot of times isn't enough to bring it out. So let's first see if you have a weak muscle. What did we have before?
That's very pretty.
But we did something. Oh my goodness. That we did crucial.
Check it out.
Okay, so those are strong. Those are strong. Oh yeah. Now breathe out. Make sure we're not missing. Now breathe all the way out, like you got nothing left. No, that's. It may not be. So, a weak muscle will strengthen when air is forced in after a forced inspiration. So you breathe, forced to inspire, and then you. I think that's more.
Hey, Doc, before you go, can you give me the landmark definition? Rounded part is occipital, and
You're coming up
This
with
is
the
the
palate
occiput, and that's the stem. Okay.
in the mouth.
got it, okay.
Yeah. And this is like your vomer, and actually, when I'm pressing on the roof of the mouth, I'm not pressing directly on the sphenoid. I'm pressing through the vomer, and the vomer is pressing in the tongue. Okay, so a weak muscle will. This is kind of the classic go-to definition. A weak muscle will strengthen when we forcibly inhale, and a strong muscle will weaken after a forced exhale. That's why I did on a couple of you guys. I had you fully breathe out to see if we were missing something. And let's have you stand again because we have those lats, and they cleared with the cruciate. They're strong muscles now, strong in the clear, all the way out. Now, still there. Breathe in. Breathe all the way out. All the way out. There we go. All the way. Hold. Yeah. So I am going to have you sit. And there's different ways to do this, but I'm going to use a distant muscle test. Therefore, that's a strong muscle. I want you to touch one mastoid and your cruciate.
On the same side.
I'm sorry, just to the left. Still, you want to. Now, touch the other mastoid and just to the right of the cruciate. So it's on the left. It's usually on one side. I find it on both sides sometimes. Now breathe in. Breathe all the way in. Keep going. There you go. Hold. It only strengthens to a forced inspiration. So that's, I actually know where my contact points are, and I know what my vectors are. And I know which side it's on. So I can go right. And back. And gloves again. You just one glove. If you guys want to come around, please do come around. I normally do this standing over the patient. Sometimes it's ahead of the patient, but I can reach around. I'm going to be on this mastoid, right? Now I can take it even further. We could make a strong muscle. Strong just like that, and I can challenge this. Just off to the left. Press and release, get a positive rebound. Press and release, breathe in deep, hold your breath, and it's negated by the breath. You didn't even have to do it first. So that's going to be my correction. Good job. So I'm pressing forward on the mastoid. And pressing just to the left of midline, Ida S. Now breathe in. Now I'm feeling for motion at the mastoid. And, ooh, there it goes. challenge it again, just to be overly thorough. Sit up, please. And go ahead and make sure this is still on. TL the left. Breathe out all the way. Make sure that breathe. And that's good. Breathe in all the way. Go on. Now stand again. Because remember what? She weakened, the lats weakened on a forced expiration. Everybody remember that? Strong and clear, breathe all the way. All the way. And I'm going to have you go back to this side. Breathe in. Breathe out. All the way. Oh, that's really good. Okay, have a seat. One more thing I'm going to check, and we're going to learn this tomorrow. Hands up. Left hand to your left. She's still got a category 2. If we don't fix that, this will eventually come back. It will. Maybe. But we were going to do category 2 tomorrow, so I can't really fix it now.
Hold on to it.
Hang on to that. Don't mess it up.
Okay.
But try to have the TL back on. See there? Yeah. Okay. We'll fix it tomorrow. Yeah. We can fix it after we're done tomorrow. I've already thrown enough for you guys to digest. So. Speedo-based learning. Let's see. Should we go back
Yeah,
to
you can go,
at the beginning?
well, no, because still was at the start. We still have. Here. Oh, inspiration assist in your back. And then you can go. Oh, you two have
Oh, no, literally, I don't like math. It's just I want to not write it. So it isn't my goal. And for the year.
Get up here.
Me?
Yeah.
I'm more
I love it. You have to name it.
She has the fourth grade on the bottom.
Yeah, you're about to
Okay, so which muscle would you Okay, everybody, yeah, still, okay. Now breathe in. And breathe out. So he strengthens on a breath in. Do we think it's a cruciate? We did your cruciate, yeah, so it's probably okay. Go ahead and TL your cruciate again. Breathe in, breathe out. No, it's not making a difference. TL your sagittal. Baby, breathe out. No, it still weakens on out breath. Okay, so it strengthens. Okay, now I want you to TL. Right. He's TLing right at the back of his right mastoid. I'm going to do both. So, okay, breathe in. It's just weak over. Now come over here. If you can reach around behind my feet. Breathe in. Okay. Just put your hand right on your oxygen there. Okay, breathe out. Yeah, it's just, okay, lay on your back for me. Please. So he has a basic, or spinobasal is like a extra deep fixation of the occiput and the sphenoid. The basic inspiration is basically a fixation of the occiput. Usually on one side, between the occiput and the temporal. So, I'm gonna use an indicator muscle here. Have you touch once again there. I think there's something going on with his pelvis. That's why with him sitting, we may not be able to touch over here. So we have a positive TL after mastoid. That's diagnostic for inspiration assist. So I'm going to go to, and we know it's inspiration assist because he's strength on inspiration. We could retest that if we want. Now breathe in through your nose, and let it go. So I've got my fingertips here. I'm kind of lifting on the mastoid. He breathes in through his nose, and at first I'm feeling for just the motion. A lot of times the cranial bone will kind of move into your hand. Now, as we breathe in, the mastoid should move posterior and slightly medial, right? So as he breathes in, I should feel that mastoid kind of moving against my fingers. It's subtle. Breathe in. Now that I kind of feel it, now I'm going to put a little more pressure, and I'm actually going to resist the motion that mastoid is trying to do. I'm kind of going to, and breathe in nice and deep. Good. And about two more just like that. And again. And one more. There we go. I always do that with patients because I want them to know that they're only going to have to do this a few times. Not just, and plus it makes it seem like I really know what I'm doing, which sometimes I do, but sometimes I'm not sure. I still haven't felt it yet. So I'm hoping I'll say, oh, give me about 3 more of those. Like I figure that's what it's going to take, but I don't know. Sometimes I need 5. But it seems to help them feel more, more kind of secure in the process. I'll breathe it again. If you're really good at managing people and making them feel comfortable you can be a pretty mediocre practitioner. I'm just telling you, and have a great practice. And I know a lot of them that their patients absolutely love them, but they don't really do that much. But they feel really safe and comforted when they go. And heard. Go there. Go there. Go there. Okay. You know what? Throw me up. I know I'm going off script, but I'm going to do it because if it requires a second dose, I'm going to steam my tube. I'm going to turn it into a steam basin. This is what I would do in my office. Relax your jaw. Now go ahead and breathe in. Same thing, pressure, same kind of pressure on the mastoid. And then I to S pressure just to the left of midline. But trying to feel that vomer. The vomer is really your push rod up into that. You ever been hit that?
I've had a couple of concussions.
Really? Touch there again. Okay. So he's good at this. Yeah. Cool. Now sit up. We came in on the left, didn't we?
Yeah.
Yeah, come up again. Who's the right left?
Left.
Left. Oh yeah. Woo, baby. Breathe all the way up. Yeah. Very nice. Yeah.
Question. So like in office, someone comes in and they have a weak, or just like a weak muscle, and then on inspiration, then you would TL behind the mastoid to see if the inspiration is.
Probably.
Okay.
I would probably TL all over. I would definitely go to. I would screen with the breath in. And if it strengthens, and I might just file that time being and then go. Depends on what I'm doing. And just realistically, when I'm actually doing this in real life. Usually by the time I get the patient on the table, there's usually like 4 or 5 things that I know. And I have to determine what's needs to be done. And that's kind of how my day goes. So, but anyway. It's really close to midline. I mean, if you remember the anatomy inside the skull, that at flat plate, you want to be able to. I honestly don't give it a whole lot of laterality. If you push very far off midline, you're going to be on the hard palate. You're going to be and you're going to feel the flex in the hard palate, but you might not be driving that force through the bone. And that's what you really want. And when you're really on the right spot, you can kind of tell. You do a few dozen of these, and you'll start to feel. Very little. You're kind of trying. It's almost like you're trying to picture how that vomer is going to push up into the sphenoid. The mastoid is going to have a lot to do with bringing up this oxygen, because that's a lot of where it sticks in. That's why TL's on that side.
Are you pushing like towards the mastoid?
I'm pushing straight
up.
I guess.
And this
Pretty much straight. Yeah. So if I was just because you're right close, I would be this way on her master. I mean on her hard palate. And I'd be almost directly midline. Back here I'm pushing. And I'm really more holding. See, the bones are naturally trying to go this way. And more than anything, what you're doing is you're kind of getting in the way of that to build tension. It's kind of like waking up a muscle. If a deltoid's kind of, but what you do is you kind of wiggle it around a little bit, maybe spindle it up a little bit, and maybe stretch it a little bit, and then it wakes up. And kind of the same thing happens with the movement of the frame. You just get a little sluggish. So you're taking advantage of the spring tension that's built in there to get them to free up. Now the cruciate and the sagittal were very much direct. We just directly followed the motion. We weren't rebound. The sphenobaselar is a rebound correction. That's maybe the same as we do in the spine if we're doing it respiratory. So this is where you TL. So if in doubt, when we workshop here in a little bit, whatever weak muscle you can have them breathe in and see if it strengthens. And then maybe it does, maybe it doesn't. Then have them TL each master. Try that.
So a regular breath in is
Inspiration.
cruciate, sagittal, or inspiration assist.
So you can challenge it like we did on. What's your first time again? Cole. Cole, I'm so sorry. Like we did on Cole, we did a challenge. We did a challenge. Yeah, didn't we? Yeah. No, we did a challenge on Alyssa. I'm totally like getting now what we did do. We did so many. I had so many cruciates in my fingertips. Forced breath in, speed waste there.
Forced breath in is a weak muscle, though. Yeah. It is a strong muscle.
A weak muscle will strengthen to a full forced inspiration with a speed base. Also, a strong muscle will weaken to a forced expiration with speed base. Like somebody had that. Did you have? So the correction is what I just did with Cole. We found out what phase of respiration, and that's what we corrected on. You kind of increase the cranial, the way we do rebound cranials, you start kind of light, you kind of increase the pressure, kind of like when you're muscle testing, when you're testing a muscle. It's kind of a crescendo. That seems to work best. But the key is for your hands to listen as much as they're talking, as far as much as it is. So expiration assist is going to be the same TL with inspiration, with the regular respiratory correction, but it's going to strengthen on exhale, and then you're going to be in front of the mastoid. These are kind of rare. I almost never do them, but they exist. There's an expiration assist. Weak muscle strengthens on expiration. Like, right? See? Yeah, you just go around in front of the mastoid. The correction is the same as it's a rebound correction, so it's the same as the challenge. 4 or 5 respirations, sometimes it goes in 2. So in general, cranial, and this is for your 100-hour test, and for your life in general, the classic nutrient for cranials is, and we talked last session, I think a little bit, you guys are familiar with the zinc test, taste test. We should have had Daniel, he probably would have been willing to bring a couple of bottles of zinc solution. We could have done it. That'd be kind of fun. But zinc, remember, is really important for the production of hydrochloric acid. Really important for the immune system. It's important for blood sugar. It's all over the place. So if you do this test, just to review, but just enough to cover the tongue usually. Have them toss it in there. Don't swallow it. Move it around and raise their hand as soon as they taste something besides water. And if their zinc levels, this is how they interpret the test. If their zinc levels are good, it'll taste really bad really quick. It tastes very metallic and kind of fuzzy. It's just a weird taste. If they don't taste it, they need zinc. And I've had people sit there for 20 seconds. I don't taste it. You need zinc. So it's seems like kind of a hokey, old-fashioned test, but it's really, and it's essentially costs nothing. I've sold far more zinc doing this than for any other mechanism. Anyway, this is the zinc taste test. You can read this and try it. Oh, there's Cannon Beach again. Okay, so we've kind of started.
I think there's one more in between that.
Oh, yes. There will be tenderness over the wing of the sphenoid. That's one of the indicators. But that can be for all kinds of things. But there'll be pain on the side of the sphenoid. Alyssa had a sphenoid. We should check. Were you tending there? Are you tending there now? This is the TL like we did. I think this is a little far off midline, and I also think it's a little far forward. Probably just. As you can see, the correction is supposed to have this kind of vector. I think, once again, I think it's probably less than that. I think what's really effective is a little bit. That arrow is supposed to be inside. Expiration is just the opposite. Like strengthen, they weaken, or they strengthen on forced expiration. And a strong muscle may weaken. No, that would be this. Scratch that last time. Tenderness, I think that might be doing the TL. And the TL is the same for the expiration of the inspiration. The challenge is going to be different. There's the challenge. It's just the opposite of the other one.
They're going more towards the two feet forward,
Yeah, you're far enough back. You're not going to be
like
crowding.
not on the teeth, but
Yeah.
their direction is.
Yeah, you're just still on the palate for sure, but yeah, you're going in that direction. You might even be kind of up against the dental. So anyway, this is the sacral thing. We did this on
You're done. You're right. That's the last one.
Okay. So lastly, in this last little bit of time, you guys have the oomph. See if you can fix the weak muscles you found. Now, focus on the stuff we did today. Check them. You can check TL here. We can check a TL here. TL here. TL here. Now, TL here is going to be cruciate bone. This is going to be sphenobaselar, sagittal suture, and of course, inspiration, expiration assist on the mastoid. If none of that shows up and you still have a weak muscle, then you go into the muscle and see if you can spindle it up. See if you can spindle it up and see if that turns it back on and keeps it on. Might turn it on and keep it on. Probably won't. So if that happens, then, well, anyway, if you find a weak muscle, call one of us over and we'll help you out. But start with the cranials. Inspiration and expiration, see if that's got the strength, and then go to the different TL.
So the breathing is breathing. These are just like ways that you define.
It's like which one? The breath is basically all both cranial and spine. So yeah, the breath and you have 3 options.
Okay, got it. So then you can feel this.
Okay. Yeah. So the breath puts you in the ballpark, and then you're like, okay, chest, chest, test,
And then for skating basics, the normal movement is like on foot going under. So they kind of like peek up to you. So when you're just it's like
yeah, it's almost like you're trying to like break it free. But you can do it. It's kind of that's why it's like an assist.
go open.
So these are very much an things, right? So like you're just using the breath. You barely have to. Because the mastoid is hard enough. I don't push it.
Okay.
Not really gonna risk that.
Well, thank you.